Hi, and welcome to Win-Win Women. We are a different kind of doula, and I am Maureen Curis here with my co-host Colleen Hughes, and our other co-host Kathleen Putnam is on a hiatus today. But we are part of the Gentle Passage Doula Collective, and we are on a mission to share with you information that we feel is important for you to know about end-of-life issues, for information we feel is important for you to know about either doula work if you're a doula or hiring a doula. So I'm going to have Colleen kick off our show. Today we're talking about CPR and the terminally ill patient. So Colleen, take it away.
Oh, thanks, Maureen. So I'm gonna share with you a scenario. So consider the following, okay? So Nancy's husband has had Alzheimer's disease for 8 years, and he's now in his final stages of the illness. And after discussion of end-of-life issues with her family, Nancy has decided to let nature take its course. And if anything of an urgent medical nature happens to her husband, she just wants things to roll along naturally. So she's told her doctor of this decision, and he's concurred. And one night, Nancy wakes up to find her husband having trouble breathing. So reflexively, without thinking, she calls 911. And by the time the paramedics arrive, her husband has stopped breathing completely. And the paramedics leap to do their job, and they immediately administer CPR and take him to the hospital. So by the time Nancy arrives at the hospital, her husband is connected to a ventilator and numerous IVs. Unfortunately, this is exactly what she did not want for him. And so our show is around these types of scenarios and the truth about CPR and the terminally ill patient. And so, Maureen, I would love to hear what you think about all of this.
Well, gosh, Colleen and I, we're both nurses. So Colleen, how many times we've both done ICU nursing have we taken care of patients on ventilators that were just like Nancy's husband, that might have expressed that they didn't want CPR, they didn't want heroic measures, but they got them anyway. So really today, we want to clear up some of the myths and misconceptions around CPR. CPR, when it was first developed, it's really a procedure if someone stops breathing and their heart stops, or their heart stops. They could either have a heart stop, breathing stop, or both. And it is an intervention to restart the heart and restart the breathing process. So what it entails is force on the chest, pumping, so you're doing deep compressions. It has to be 1 inch to 1.5 inches compression on the chest to be adequate for blood perfusion to the brain. So, the people that are just pumping away, that's great, but they might actually get a heartbeat back with that. But the complication arises if you're not getting the blood perfusion to the brain. So I think that's the first thing. You have to really pump hard, and it is hard. Colleen, you've had this experience. I know. As a nurse, I've probably only done chest compressions about 6 times in my career, because usually I was there with a whole staff of people and we all took different roles. But boy, I'll tell you, it's not fun when you feel those ribs cracking under you, because as you're pumping down, because you have to pump hard enough, press hard enough to get that blood perfusing.
I think there is a statistic. Well, first of all, it has happened to me as well. The last CPR I ever did in my life left me with the sound of ribs cracking on a woman who had no DNR, and we'll talk about this, no advanced directives, no family. And everybody, as a medical team, we had to perform the CPR. So I was up on the bed performing with a board underneath her, performing CPR, and her ribs cracked. And I had to keep going. And they
Yeah.
kept saying, where is the doctor? We can't stop this until we hear from him to stop it, because she had no directives or no family. And so finally they did stop it. And he, did eventually get back to us. And he says, yeah, you did the right thing. And he said he'd write the orders and said, well, but this is the nightmare you want to, you want to avoid. But what happens, I read somewhere that 81% of the time the ribs do crack.
Yeah.
In a terminally ill patient, a patient who's very frail or fragile, 81%.
And yeah, that's what this show is really about, the terminally ill. So we're going to talk a little bit about CPR. Was really designed for healthy individuals that have a cardiac or a respiratory event. It could be because of an accident. So many reasons that they might have this. They might, let's just say, have pneumonia or something, and somehow they stop breathing. But so part of CPR includes the chest compressions, as we were just talking about. It includes putting a breathing tube in for ventilation. So it's, you've seen them when they put that breathing tube in and they're on a ventilator. It helps get oxygen to the body. It perfuses the brain with oxygen. And they usually do that if you're in a hospital setting while you're still getting your chest compressed. Electric shock, that's another thing that is part of CPR. In the best case scenario, you want that defibrillator close by, or an AED device where they can shock you. On TV, we see it, stand clear. They do that in the hospital too. Everyone has to stand back. And then in the hospital, they're using a lot of medications to restart the heart and help blood flow. So as we go through this, we're going to talk a little bit about statistics in hospital, but CPR really works best if you have a healthy body, and CPR is started right after your heart stops. It's less likely to be successful if you're weak, if you're elderly, if you have a chronic illness. So often we think of that chronic illness being cancer. That's a big one where, if you have end-stage cancer, you really want to talk about, do you want CPR or do you not? And really, that's our choice to make. There's no right or wrong answer, because we get to make the choice for ourselves. But there's also many other terminal conditions that we don't think of, end-stage renal disease, end-stage dementia. As I think that was the story of Nancy's husband had Alzheimer's, end-stage cardiac disease. At what point do you think that CPR will be effective or not effective? So, Colleen, you were going to talk about, I do want to give a couple facts though. National studies show that 18 to 30% of people that receive CPR in a hospital setting, that they survive. So that's in a hospital setting. The number's obviously much lower outside of a hospital setting, because you don't have all the bells and whistles there to jump on it right away with the breathing tube and the defibrillator and the medicines to start right away. But so 18 to 30% survive and are discharged. But of those that survive, 28% have significant neurological disability. Because remember how I said that the compressions have to be deep enough and strong enough to perfuse the brain with oxygen. So when that does not happen, that leads to neurological disability. And then there's some national studies that say that show that 2% of nursing home residents, people in assisted living, long-term care, who receive out-of-hospital CPR survive. So that means 2%, let's say 100 patients, people in long-term care, assisted living, need CPR, 2 of them will survive. So out-of-hospital means it means acute care facilities with ER and ICUs and all of that. It doesn't mean, you're in a long-term care hospital. That's a much different setting. So this is the acute hospital where you'd go for the emergencies.
Maureen, those statistics are really,
they're sobering.
They're sobering. They're very impactful. And then, of course, I have a little set of statistics just to add to that, which is those survival rates after a person is discharged who has had CPR in the hospital. Now we're talking about people ages 70, 79, their average survival rate's 18%.
Yeah.
So it's really poor. And then if you're 90 and you've had CPR in the hospital, you get discharged, it's 12%
Yeah.
of survival rate. I mean, it just goes, and then 80 to 89 is 15% survival rate if you've had it and then you're discharged, because it doesn't solve the problem of all the multiple illnesses or chronicities or whatever you have, even if you're not terminal.
Well, and you know what doesn't, so in that 12%, or I can't remember what you said for the 80 to 89, it doesn't, you might be discharged, but does it take into effect the cognitive impairment? So they're
Oh,
not saying about
absolutely.
so you could be discharged with severe cognitive impairment.
Yeah.
So, you can survive. There's a survival rate, but there's also a survival rate with no cognitive impairment. And that's really, really low the older we get.
Right. So, we're talking about real life. Let's try Hollywood, because I always, people, I like what Barbara Carnes always says. In fact, she has a T-shirt made up, uh, dying isn't like in the movies, it's just not. And so Hollywood often gives us these storylines of these miraculous recoveries with CPR. And it's usually in a young person. They may have been in an accident, shooting, or drowning, and they have this miraculous recovery. Well, they never show on TV the brutality that you just described, the depth of the compressions, the amount of the compressions. And they never show that because they always make it look like, oh, boom, 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 up, look at this, And so that is another thing. They don't show the person with terminal illness with metastatic cancer who you just broke the ribs because you're trying to save their life, which is really essentially over. So I think it's a great disservice of Hollywood, and it's what people watch and it's what they believe, which is really unfortunate, because really the only chance you have for survival, and I say this with caution, because again, it depends on what you have and why they're doing the CPR, is in a CCU with nurses and doctors there already and monitors and everything already set up. That's your greatest chance, but I do
You're
know.
saying you're saying that, and makes me go back to when I worked in the cardiac ICU, and there was a man that was in, and he was getting ready to be discharged the next morning. We were working the night shift, and all of a sudden his monitor just went flat. Well, we were able to jump on it, and we were there. We were in his room within a minute, and he recovered, without impairment, cognitive impairment. It was because everything was right there. I mean, it
Right,
was, yeah.
exactly.
So, sorry, I interrupted you.
No, but I mean, I
Back to
think
the
we have been
politeness.
talking and I was laughing because you had some interesting statistics from TV shows. Remember the old ER and with George Clooney
Oh,
and
I was addicted to ER. I lived in
yeah,
Chicago when it was being filmed. But yeah, okay. So I read an article that the NIH, some faculty at NIH did, and there's a TV show called Rescue 911, which I've never watched, but they said they had the best TV survival rate at 100%. And
uh,
then they compared Chicago Hope and House, which I think I've watched House once, but between the two of them, those two shows combined, in 91 episodes, CPR was performed 46 times, and they had like a 69.7% survival rate. Well, that's, as we've just told you, that doesn't match what the studies have shown from hospital CPR rates. And it's just amazing to me. But Chicago Hope on its own has a 64% survival rate. And ER, my favorite show, had a 65% survival rate. So, I used to always laugh because having worked in, like, I was in the throes of working in ICUs when I would watch ER, and they'd come in and start CPR, and then all clear, everyone stands back so they can defibrillate the person. And then, the person comes up and like the next day they're discharged. It's like, yeah, that never happens.
That's not true.
That's never happens. But we've done a disservice, because now, even if you don't watch those shows, it happens enough in movies, it happens enough on TV, that people see that and think, oh, I want CPR. And without understanding the true consequences if you have a terminal illness. And like I said, it's our choice. We all get to choose what we would want. But I always encourage, when I work with people for advanced care planning, think of where you're at today. Because this decision you make about CPR, it doesn't have to be forever. You can say, heck yes, I want it today. I'm 60 years old. I'm healthy. My chances of survival are good. But you know what? Now all of a sudden I'm 70 and I have osteoporosis. I have coronary artery disease. Let me think about what I want. And now all of a sudden I'm 80 with osteoporosis, chronic coronary artery disease, and maybe I have some memory issues starting, some cognitive decline, and I'm 80, and all of a sudden the statistics for my survival have gone way down just because of my age and my health condition. So, that's the time to start thinking, each decade of your life, or each life limiting illness or chronic illness diagnosis, review, is this really what I want? Would I want to go through that? Knowing what I know about the survival rate in hospitals, the cognitive impairment, if I'm in a long-term or assisted living facility and I'm in my mid to late 80s, would I want to be revived if something happened to me there? So these are all questions that people should really be asking themselves.
So, I think what you're talking about brings up another interesting, there's nuances to this, and it's the DNR and the advanced directives. And DNR essentially means do not resuscitate. It used to be DANR, do not attempt, resuscitation. And sometimes you've seen this, or it has been on a record and then it's ignored. And sometimes the same thing with an advanced directive has happened. I've heard these stories over and over. But a DNR essentially is part of an advanced directive, because if you look at the advanced directive, Maureen, and you know this well, is that it tells specifically what you want and do not want, and in what conditions. And it mentions the ventilator. I do not want to be on a ventilator if I am not going to be able to recover fully and have quality of life. It's the verbiage is somewhere in that ballpark. And so, all states accept this advanced directive or do not resuscitate. But, what I've noticed recently is my advanced directives are now uploaded into my chart, and that's electronic form of charting. And it's a medical system, and it's a system wide. And so doctors if you get admitted to the hospital that they affiliate with, they'll see it right away in your record, right?
Right. And, and there's some medical records that talk with each other, like the Epic system.
Yeah.
If a patient goes to a doctor that uses Epic because they're part of a hospital practice and they end up in Florida and that happens to use Epic, then maybe it can talk to each other. But the DNR order still has to be written by a physician in the hospital. So even though it's in your advanced directive, the DNR order, from what I understand, it still has to be written by a physician. So just because it's in your advanced directives doesn't mean it's 100% followed, because you want it so
well,
the
big thing then is the POLST, the physician orders for life-sustaining treatment. It's also called the MOLST, MOLST, in some states. But a POLST is for people who've been diagnosed, or, I have one, I haven't been diagnosed with a serious illness. So I say it's for anybody, really. And it's filled out by your doctor.
65 and older.
Yeah.
Anyone 65 and older.
And so, yeah, and my doctor went over it with me, which I was very impressed. And we uploaded it into my chart. So that one, the physician signs, and
Right.
that one should be carried out.
That one, okay, so the pulsed form, that usually on a bright piece of paper. Our state in Washington is
Green,
bright lime
green,
green.
lime
I think
green.
California is bright pink, but it's something that the emergency medical technicians can see right away when they come in. So I think they tell you to put it either on your refrigerator, on a cupboard, on the back of your front door, something where that emergency medical personnel can find it. And that order can be, it's the one that the emergency medical technicians, the EMTs, the paramedics can follow outside of the hospital. DNRs are sort of, some states say yes, you can follow them outside of the hospital, others no. And then the pulsed, it's really, I think it's been changed to portable orders and the most medical orders for life-sustaining treatment. But there's a lot of question. If you're traveling, take those with you. Take them, because even take that in your advanced directives. If you have a signed DNR, take that too. Take everything. If you're going to be out of state, some states will honor it, some states might not. It's state specific. The pulsed and the most are not federally mandated. They're state, they're by state. So take it with you. And then if you're moving, tell your new provider in a new state. But if you're in a new state and something happens, your family knows you have it, let's say you're traveling, the hospital personnel at least then will know your wishes, and do their best to follow your wishes. Sorry, I jumped in on that post. I'm sort of passionate.
No, I think all this information is really valuable to the public. And I also think the decision-making process is extremely hard. For one thing, why is it, the most logical, most educated people in our society are so resistive to looking at death and talking about their own mortality? And, and I take that population, but let's just say we're all human. And what is it that we have difficult time looking at our own mortality when other cultures seem to do that really well? And because we have that difficulty, we don't have all the information. And that's the other part of the decision making. With the physician, they're not trained in medical school how to give these conversations, how to start them. And they're now starting to look at it more because there's a lot more research and articles done on it. But it's like, if your physician doesn't have the information to tell you how brutal CPR looks and that it does not look like Hollywood, where are you going to get that information as the average person in society? And so I think in the decision making, we don't have information that we need because we're afraid to talk about it. And so nowadays we are seeing more and more people talk about it, people who talk about it like us, not just nurses, but as end-of-life doulas,
Yeah. End-of-life doulas are great about talking about this stuff because, let's face it, physicians still have a hard time talking about this. They get attached to their patients. We've talked about this before. I know, hey, do I want to have to consider my death? No, but I'm prepared. I want to be prepared if something happens. So having these discussions about CPR, or what I would want, are so important. But the thing is, so often it's the patient that has to bring these up with the doctor. It's the patient that has to take the first steps. They might, I've been in the hospital twice in the last year, 15 months, and they ask me, do you have advanced directives? Yes, I do. Okay. And that's all they ask.
Yeah.
They don't say, hey, do you want to go over? Let's talk about your advanced directives. What would you want? Not once have I been asked that. And that's why we as patients have to be advocates for ourselves, or as the decision maker. But you and I, when we were talking, preparing this, you had made a observation that the biggest mistakes are made during the decision-making process because we skip over the important conversations. We're too afraid to have them, or the doctor's too afraid. They don't want to give up hope for us with the term, us with the terminal illness. So they they sort of talk around it, and they don't always get the message across that, hey, you know what? You're stage 4 metastatic pancreatic cancer. Your chance of survival past the next 6 months is probably 0. Let's just, not all stage 4 metastatic cancers are that way. I'm just making this scenario up. But you know, we can try this other treatment. Let's try this other treatment.
Exactly.
And this might give you a little time.
Mhm.
And that's why, you know, you and I are both big fans of Atul Gawande, Being Mortal.
Mhm.
There's a book, Being Mortal, and you had just recently sent me the link to the documentary again. There's a documentary out, and there's going to be a feature film made about being mortal. And I just think everyone should watch that. Everyone that has any fear around death should watch that and see what it's really like for these people walking this journey. But he asked 3 really important questions, and he learned this from experiencing his father's death and walking with his father on the journey of death. But I think they're so powerful and so important. Do you know what they are? Do you want me to say them?
Well, I I wanted to say one thing before you give those 3. You have them too, I think, because we both love that documentary. Is that I recently talked to a physician that when he found out I was an end of life doula, he shared with me his guilt he had over his father's death. And the reason why was because he saw his father as terminal, and every intervention to save his life was done, and his father suffered through all of those and still
Yeah.
died, and he had guilt over that. So that made me feel good about the authenticity of his sharing, and about him realizing that that is not the way we want to go. And
Yeah.
so that those 3 questions have a lot to do. I think they're great.
Yeah. Why don't you share them?
Well, you know, Gawanda says in this, he says, here's the 3 questions. What are your fears and worries for the future? What are your priorities if time becomes short? And what are you willing to sacrifice and not willing to sacrifice?
See, I think that so many people just automatically sacrifice quality of life for time because they're not asked these questions. So they think, oh, of course, I want to buy more time. But they're not told that that time might be time of pain and suffering. It might not be, but it might be. So these questions are so, so powerful. I mean, those priorities. What are your priorities if time becomes short?
That's beautiful. I
That's
love.
just so I encourage you, Colleen, I know you encourage people too. Anyone listening to this, make these 3 questions questions you ask. If you're a doula, if you're a nurse, if you're a healthcare provider. I have a son that's in medical school, and I gave him that book to read. And um, these are the questions you ask so that we can so people can make decisions based on what their needs and wants are. Okay, now once again,
We are almost out of time again. And oh, as always, thank you very much for joining us in this discussion, in this conversation. And we're from the Gentle Passage Doula Collective, and we have and if you want to catch us, by the way, we're on Facebook under Challenging Conversations. Let us know if you have a specific topic you want to talk about or hear us talk about. And we're excited because the Gentle Passage Doula Collective, we have a doula training program, and it is starting in January 28th and 29th, I think. It's a Saturday, Sunday, and then we have a whole package where we have webinars all year long. And we also have another one coming up in April that's in person, and we have a virtual that'll start in March. So we really want to meet the community's needs, and we want to see a doula in every long-term care facility or assisted living, or frankly, I'd love to see them in hospitals too. I'd like to see more doulas around in the healthcare system. We have a death cafe. If you go to Gentle Passage Doula Collective, you will find our death cafe, and you'll find our training program information. And what am I leaving out, Maureen?
Well, our Death Cafe is the second Friday of every month at 12:30 Pacific time. And yeah, it's under our events tab on our website, gentlepassagedoulacollective.com, like Colleen just said. And yeah, it's wonderful. There's no agenda for a Death Cafe. It's just whatever comes up for the conversation by the attendees. Whatever you want to talk about, we're there just to talk and listen.
Oh, thank you. And thank you, everyone. We'll see you next time. Bye-bye.
Bye.